Hi, my name is Dr. Joan Kaufman. I'm one of the developers of the paper and pencil KSADS-PL, as well as one of the developers of the web-based KSADS-COMP. This training today is on guidelines for administering the Clinician Administered KSADS-COMP. I want to be discreet in my disclosures. I have served as a consultant on multiple industry-sponsored pharmaceutical clinical trials. I won't be speaking about any of those today, but I'm also co-owner of KSADS-COMP LLC, and I acknowledge that I am biased in my discussions about the value of the KSADS-COMP, and I have conflict of interest in regards of benefiting from your potential use of it. But nonetheless, I think it's a worthwhile tool, and I'm going to walk you through administration guidelines for using it. So, outline of our training today. I'm going to start off by an introduction to child psychiatric diagnoses and the KSADS assessments, give an overview of the clinician-administered KSADS-COMP, allow time for viewers to do some independent exploration in our demo site, review some frequently asked questions related to the KSADS-COMP, talk about differential diagnoses, then present you with specific KSADS-COMP review questions. So, there has been a desire in psychiatry for a long time to try to figure out what parts of the brain are associated with which psychiatric disorders. But nonetheless, what we've learned over time through decades of research now is that the brain is not organized according to either the DSM-5 or the ICD-11. The National Institute of Mental Health has an initiative called the Research Domain Criteria Initiative, or RDoC initiative, which hopes at some time to be able to map various brain systems to various different types of behaviors and symptoms. And it is the goal that potentially by 2030, our psychiatric diagnoses will have something the equivalent of the pediatric growth chart, where we can look at functional connectivity and be able to map abnormalities to suggest the need for early intervention or for diagnoses. But we're not there yet. Currently, in Diagnoses 2022, and probably for the next decade, our best diagnoses are made by interviewing both the youth and the parent, and oftentimes using self and parent report questionnaires, reviewing medical records, as well as sometimes getting collateral information from children's teachers or Child Protective Services system if they're involved in that system. Now, a little bit on the history of the paper and pencil KSADS. The first version was published in 1978 by Dr. Kim Pujantic, who really was revolutionary in his time. At that point, there was never an accepted belief that you could ask children about their symptoms, and he really was at the forefront of modern-day child psychiatry and bringing biological psychiatry to the field of child psychiatry as well. In 1997, my colleagues and I modified the KSADS for DSM-4 criteria, and the other change we made is we divided the sample questions into a screen interview and then supplements. And part of the rationale for doing that is, as a postdoc, I had done a lot of SCIDs, and like most standard psychiatric interviews, you screen for a disorder, and then you ask all the questions related to that disorder, and you continue through. And I can't tell you how often I was an assessing adult. I screened for mania. They screened positive with up mood, and then they scored positive for decreased need for sleep, hypersexuality, and the like. But only at the end of the interview did I find out that they were using crack cocaine. And technically, I needed to go back and re-ask them if the decreased need for sleep, elated mood, extra interest in sex was all associated with their cocaine use. But usually people are too tired at that point. So when we did the 1997 version of the KSADS-PL, we divided it into a screen interview and supplements so we could get a good diagnostic overview before we did detailed probing to find out if, say, disorders that might influence the presentation of one, like substance use influencing the presentation of mood disorders, if they're related, find out about the substance abuse first, and then you can do much more targeted programming, and you have no need to then go back and re-ask questions that you've already covered. All right, so that 1997 version, the KSADS-PL, has been used in a lot of pediatric clinical trials studying everything from schizophrenia, bipolar disorder, major depression, ADHD, oppositional defiant disorder, PTSD, anxiety disorders. And many of these clinical trials have resulted in new indications for uses by the FDA. It's also been used as a validation instrument in large-scale epidemiological studies and in numerous studies examining the longitudinal course, clinical, neurobiological, and genetic correlates of child psychiatric disorders. There are, however, many limitations to using the paper and pencil KSADS. First and foremost, it is 215 pages long, which is a lot to Xerox. The administration time is minimally 3 hours in doing the interview with both the parent and the child, which is not typically feasible in routine clinical practice. The paper and pencil KSADS also has unique scoring criteria associated with every different symptom, making training and the establishment of inter-rater reliability problematic. There are often frequently errors also in selecting which supplements need to be completed and in tallying symptoms. Typically, when you would do the paper and pencil KSADS, if you screened positive, you would write a little note so that you know, screen positive in depression, need to do that supplement later. But that can be difficult to keep track of those sorts of things. So some of the advantages of the web-based KSADS-COMP. Administration time for the clinician administered KSADS is about half of what the paper and pencil, typically an hour and a half in doing the interview with both the parent and the youth. It has excellent inter-rater reliability in scoring individual items, even among first-time users, and we'll talk a little bit more about some of the changes we made to increase inter-rater reliability. It also automatically selects which supplements need to be completed, and there's automated scoring and diagnostic algorithms, so there's fewer human error. The instrument also generates diagnoses, categorical, as well as dimensional symptom ratings, and has automated data capture features at both the symptom level and diagnostic reports. I'm not going to read this off, but as you can see, the KSADS provides really all the major child psychiatric diagnoses that one would want. And the characteristics of the clinician-administered KSADS-COMP are really the same as the paper and pencil KSADS. It's a semi-structured interview designed to be administered in a conversational style. It is a multi-informant interview, feeling very important that you can't make a child's psychiatric diagnosis without getting information from both the caregiver and the child. And we really strongly recommend that the same interviewer does the assessment with both the caregiver and the child. Now, the components of the clinician-administered KSADS-COMP are essentially the same as the paper and pencil as well. There's an introductory interview, a diagnostic screening interview, which we talked about before to get a good survey of potential diagnoses before you go into the supplements. But what's unique now with the KSADS-COMP is we have a self-administered pre-interview that would be done on their own prior to meeting with a clinician. And what the self-administered teen and parent pre-interview includes is all the screen items that are part of the regular KSADS screen interview, and they can be completed before the clinician meets with the patient. The pre-interview only surveys current symptoms, and their responses can be reviewed prior to doing the diagnostic interview with them directly. And the responses will also show up on the screen. So you don't have to remember how they responded to a given item. As you're asking a question, you'll be able to see in the corner, oh, child already told me this is true all the time. Parent said that. And that's going to really streamline your assessment. So what I'm going to do right now is I'm going to walk us through a couple parts of getting going with the KSADS, starting with making a patient ID. So I'm going to take us over to the website. I'm going to log in. And okay, I'm going to go to this folder and find here. So you see, this is where you would list the patient ID, this far left column. I'm going to click here, and now I'm going to personalize it. So I want you to know that this is test 10, 1, and 22. And then I'm going to update and save that. So I have that. And I'm going to go back here. And so now I'm back to where I was before, and I have my new subject ID that I've now identified. So one of the things I just want to make very clear, we do not recommend that you put any patient health information, personal identifiers. We like to have only anonymous information. And while the KSADS-COMP website is incredibly secure, even the Department of Defense has been hacked into, and so we want to make sure that there's no personal information here. So now here you can see you have columns for the pre-interview with the youth, pre-interview with the parent, then the youth interview that the clinician would do, the parent interview, and then the consensus interview. So the clinician interview is based on what you get when you talk to the youth, the parent, and then putting the information together. So this pre-interview that we talked about, I can click here, and what you'll see, I can either cut and paste this, or I can just say, please email it to, and I can put the parent's email or the youth's email there. You can also cut and paste it and text it to them if they like. And if you wanted, you would click right here to actually do the interview, or just say handing someone over a tablet to do it before they meet with you. All right, so I'm going to pop out here for now. And I'm going to show you a little bit more that if you had already gotten, now these are completely done interviews, but I want to get you a sense of what it's like to see the reports. You can click on that far right column, see reports. And if you want to see the pre-interview items, you go to the symptom response comments. And right here, I'm going to say, I want to look at the youth's response, pretending I hadn't done the interview yet. I click here, show only questions asked, execute, and you can see, I can readily see all the different responses. And I see that this child is not showing a lot of depression, irritability, what have you. So that gives me an opportunity to look that over and get a sense of what the key diagnostic areas are going to be when I start to work with that child. So I'm going to go back to our PowerPoint presentation now and just sort of review some of the stuff we just did. So in order to make a patient ID that you can link with your potential other data, you would log in as we did before. You can click on it, write something personally, update and close. And again, do not use names, date of birth, or other protected health information in naming or even in writing in the KSADS. We saw how if we wanted the pre-interview, we could click right here. That would get us to a URL that we could email directly. And this is just also to show you what it looks like. These pre-interview questions can be done on a smartphone, an iPad, or on a computer. And this is what they look like on the smartphone. So you see, it's really pretty easy to read, very usable. And it does provide a very comprehensive screen that helps to streamline the assessment and identify likely diagnoses before you meet with a child. And the administration time is about 20 minutes. In my experience in sending it to parents before I do a clinical interview, about 98% of the time they do it. They're worried about their kid. They're concerned. They want to take the time to do this. And that really does make it much easier for you to do your interview with having this background information. All right, we also showed this before. If you want to look at the replies before you do your interview, you log in here. You say that you want to do the symptom response comments reports. You do the pre-interview, click execute, and then you'll see what the responses were to all the items. And you could look at that ahead of time. And as we talked about before, it's also going to show up on the screen when you are actually doing the interview. All right, so right now, what I'm going to have you do, if you have not already spent time on the demo site and had a chance to try these different things, I'm going to recommend that you pause this video, you log into the demo site, you practice modifying a patient ID, remembering not to use any patient health information, that you copy the URL to send the pre-interview link to a caregiver or youth, and that you actually click do the interview now just so that you can go through all the different items that are included in the pre-interview so you know kind of what you're asking the parent to complete. And then you can also go back onto that screen, that far right column, and review the report of the pre-interview items, just so that you can go through those different stages. And then we'll pick back up with some more training on administering the Clinician Administered KSADS-COMP. All right, so frequently asked questions as people are learning to do the KSADS-COMP. If the KSADS-COMP is HIPAA compliant and GDRP compliant, which is general data, I'm probably going to get that acronym wrong. It's the European Union's requirement for data security. Why can't we use protected health information in KSADS-COMP? You know, as I alluded before, even the Department of Defense has been hacked. So we don't want to have any information out there. Also, potentially other users within a given site could potentially open up another assessment that they hadn't done. So in the interest of precaution, we request absolutely no protected health information be put within the KSADS-COMP data. How young a child would you ask to complete the self-administered pre-interview section of the KSADS-COMP? The pre-interview section and the self-administered versions of the KSADS-COMP are designed for youth 11 and above. And I didn't show this, but you can certainly try this when you're on the demo site. The pre-interview items include, for the youth, video clips and auditory so that they can turn it off if they want, but this way they don't have to read everything. The parent version is just, designed for them to read it. But the youth version has the video clips, which really does facilitate administration. And we typically recommend for children 11 and older. Is there a save and return option if the parent or youth cannot complete the pre-interview questions in one sitting? Everything in the KSADS data is saved instantaneously. So if a parent gets stopped all of a sudden and then comes back, the KSADS will take them right to the question they were at. Likewise, if you're doing an interview and you have to stop for some reason, you can pick up exactly where you left off. No need to press any save button. Everything is saved automatically. Can the clinician portion of the interview be administered if the pre-interview items are not completed? Absolutely. The pre-interview items facilitate and streamline the assessment, but they are not required in order to do the clinician portion of the interview. Can data attained in the pre-interview questions be used to guide the sections to be completed in the clinician interview? Absolutely. Now, for research purposes, oftentimes there's a requirement that you do all the sections of the screen, but in clinical practice, that's not always feasible. And so the pre-interview items, you'll see what are the items that they scored significant. And I usually say the data from the pre-interview as well as your introductory interview, where you may pick up additional information, either things that were true in the past that you'd want to survey further. So as you'll see in a little bit, they're module selections, and you can choose as you go. You do not have to do every screen interview in order to complete a diagnostic assessment. All right, so we were talking before about the different components of the clinician-administered KSADS-COMP. Let's talk about the introductory interview. Okay, the content, it includes information about demographics, health history, prior psychiatric treatment, family history of psychiatric illness, information about adaptive functioning in school with peers, other activities, as well as additional information like whether there are guns in the home, youth gender identity, sexual orientation, and the like. Now, some of these items, like prior psychiatric treatment, family history of psychiatric illness, health history, firearms, that's data developmental history that's only obtained from the parent. But the other data is collected from both the parent and the youth. And the purpose for the introductory interview, first and foremost, is to establish rapport. You don't want to start off an interview with a kid saying, have you ever felt sad, down, and depressed? No, you want to find out how old they are, who do they live with, what do they do in school? All these sorts of things which provide a natural context for finding out about functional impairment, symptoms, and again, establishing rapport, building that sort of trust, which is essential for getting good, valid data. As I just alluded to, another purpose is you get information about functional impairment and can generate hypotheses. If, as you're doing the background interview, you found out the child's been suspended multiple times, we get a sense of their functional impairment, and you start to think about different diagnoses. If it's due to fighting, due to coming to school intoxicated, different things like that, it helps you think about, okay, what are going to be my most relevant diagnostic areas that I really want to focus on as I move into the screen section and the other components of the clinician-administered KSADS-COMP. It also provides a context for eliciting symptoms. And I often give this example, but I can remember there was one time when I was doing an interview with a 13-year-old girl, and I asked her, had she ever felt sad, down, or depressed? And she said, nope. But I had noticed earlier, because we start off the interviewing asking, who she lives with. She didn't live with her father, asking, how often she sees him. And as it turns out, she hadn't seen her father in about 3 years. And as she was talking to me about that, first of all, it was even hard for her to talk to me. She had to stop talking for a bit, look down, looked like she was fighting tears. And so I was able to ask her, when I asked you about your dad, you looked like you got sad. Were you sad? Yes. How often do you think about your dad? All the time. And in that context, she was then able to start really talking about her depressive symptoms, which were pretty consistent and persistent. All right, other components of the clinician-administered KSADS. We went over the self-administered pre-interview, the introductory interview, and the last two sections we're going to talk about are the diagnostic screening interview and the diagnostic supplements. And so here's the dashboard that I was referring to before. So after you finish the introductory interview to the KSADS, where you get the background information about the child's current life situation and the like, you will see all these different tabs. The top part here are all the different screen sections of the KSADS-COMP. If they're gray, it means they've already been completed. And down here is where you would have the supplements. So automatically, if you had clinically significant scores in the mood disorder section, the supplement is going to show up down here. So no more keeping track on little pieces of paper of which supplements need to be administered. And so you can choose as you go. Often, again, as I said, for research, you need to do all the different supplements. You can also set, if you're doing a study with 3- and 4-year-olds, you may not bother to be including the alcohol and drug use disorders sections. You can make those changes as you set up your study. But again, as the choose as you go clinically, you may also just choose to do 3 or 4 different diagnostic areas based on the information that you have. So the screen interview, as we've talked a little bit about, surveys the primary symptoms of the different diagnoses assessed with the KSADS-COMP. On average, there are 2 to 4 symptoms in each of the different diagnostic screen areas. Current symptoms, and we'll talk a little bit more about this in a second, are rated over the past 2 weeks using a uniform 0 to 4-point rating scale, which is different because, as we said, the paper and pencil KSAD had a different rating scale for every single item. The threshold that are required for clinically significant response varies depending on the symptom being assessed. So here are some examples. So up here we see the irritability item from the depression section. In the past 2 weeks, how often has your child felt annoyed, irritable, or cranky with a cranky feeling lasting most of the day? And the positive threshold response is either more than half the days or nearly every day. Now, that's a different cutoff that's required for, say, role application in the alcohol use disorders. In the past 2 weeks, how often have you gone to school or work where you've been drinking or when you were hungover? So clearly, if this just happened rarely, once, twice in the last 2 weeks, that's a red flag. And so we see the criteria for clinical significance that would push you into the supplement to look at these possibility of these disorders in greater detail varies based on the symptom being assessed. In scoring screen interview data or any of the data within the KSADS-COMP, observational data can be used. There's times where a child might say that they've got no problems with concentration, but you're constantly having to say, Jimmy, can you hear me? Can you look at me? Is this how you usually are? You can use that observational data to do your rating as well. Each of the different diagnostic areas surveyed in the screen interview have skip-out criteria to determine whether or not a supplement is needed. And if the child receives a threshold response for the current symptom, they're queried about the next symptom in the KSADS. If the response is subthreshold, they'll be asked about the lifetime presence. So it is assumed if it's true for you within this 2-week period, it has been true outside that 2-week period. The supplement will have the additional questions that will be needed to determine whether there's a current disorder, whether there have been multiple episodes of disorder, a disorder in partial remission. But as we're doing the screen, if you're at threshold on the depression item, next item, irritability, comes up. If you're not, you'll ask about the lifetime presence of that symptom. So here's a screenshot where a current symptom is being surveyed. So as we said, so this is an interview that's being done with a parent. The teen interview had already been done, and we can see the teen's response up in the left-hand corner, the pre-interview response completed by the parent in the right-hand corner. And here's my question. So I already have information from the parent and youth that this child has felt annoyed, irritable, cranky nearly every day. So I'm going to be really quick asking this question. I don't need to get a ton of information. Basically, I understand from what you've written and from talking to your child, it sounds like she's feeling annoyed really nearly all the day. Yeah, got it, go on. And so just to let you know, also on the screen, you have your criteria, so you know what's necessary for a clinically significant diagnosis. And also I want to highlight here, every single screen of the KSADS has a comment section. You can click here, and if you want, you can write notes. So if the parent goes on to let you know that they've been so cranky, they've got holes in the wall from punching it, you might want to write a little note like that, and that might be something that you would include in potentially a clinical write-up. All right, this is a screenshot for past symptoms. Okay, so if there was not threshold level current irritability, Then the youth would be asked, was there ever a time in the past that your child felt annoyed, irritable, or cranky? And again, we ask at such a level because if we just stop there, that would be true for everyone. Welcome to being a human being. We've all felt annoyed, cranky, and irritable. But what we ask is for most of the day, nearly every day, for 2 weeks or longer. So if it's yes, that's threshold. And so the past symptoms, we've really tried to ask them in such a way that it's clinically significant and would warrant further investigation. All right, so the probes in the KSADS-COMP, as in the KSADS-PL, do not need to be recited verbatim. Again, we talked about this being a semi-structured interview. Interviewers are free to make stylistic changes in the wording of the probes. And sometimes probes can be admitted if the data obtained in the introductory interview or the parent and teen pre-interview suggests no further probing is required in order to rate the symptoms. So if they've already let you know that, she's just made a suicide attempt, she's in the hospital, you don't want to ask the question about, have you ever made a suicide attempt, or when we know that they have. So you can get additional information as needed, but you don't need to ask some of these questions if you already have what you need in order to do the scoring. All right, coding disorders targeted with medication. In coding disorders effectively treated with medication, like ADHD, raters will use the past or lifetime ratings to describe the most intense severity of symptoms experienced prior to initiation of medication or during drug holidays. So we certainly don't want a kid who's maintained on ADHD medication not to get an ADHD diagnosis. So again, you'll know if they're on medication based on the introductory interview. We get information about that. So, we would then sort of find out prior to that what symptoms they had. The current ratings will be used to indicate if symptoms are still problematic, even on medication. And the diagnostic algorithms use the medication treatment history and symptom data to generate a diagnosis. So a child could get a diagnosis of ADHD combined type maintained on medication in full remission. So we know they've got no current ADHD symptoms, but we're still giving them an ADHD diagnosis because they're being maintained on medication. All right, so now I'm going to move ahead to talk about the supplement administration guidelines. The skip-out criteria in the screen interview will specify which sections of the supplements should be completed. The supplements to be administered, as we saw in that screenshot earlier, will appear at the bottom of the computer screen, so you don't have to try to remember. The computer reminds you. And in general, supplements are administered in the order that the symptoms for the different diagnoses appeared. So in general, ADHD usually has an earlier onset than major depression. So then the ADHD supplement, the recommendation is you would do that one first. You'd find out if there were longstanding problems with concentration disturbances, psychomotor agitation. And when those symptoms are asked in major depression, there will be automatic prompts. I know you've always had trouble with concentration. Has it gotten worse since you've started to feel sad? It doesn't count towards major depression if it's just part of the longstanding ADHD and there hasn't been a worsening of those symptoms. So in general, if the two disorders, you would administer the supplements in chronological order, unless the time frame overlaps and supplements our symptoms associated with one disorder may influence the presentation of other symptoms. And we earlier gave the example of cocaine use and mania. What's probably more typical in adolescence is marijuana, cannabis use, and depression type symptoms. If you know someone smoking a lot of weed, you want to find out how much weed and do the substance use section first. And then when you're in the mood disorder section, you can really find out, is the increased appetite, the fatigue, the sleeping really tied to their weed use? If it is, that's not a major depression. So again, you can administer the supplements in an order that really helps to facilitate the differential diagnosis. Here's another example of one of the reports. We talked about the symptom response. We saw those earlier. We can see the comments. Here's an example of a diagnostic report. And as you see, it lists the diagnoses and all the current symptoms. And all the data can be captured and readily downloadable with the KSADS-COMP as well. All right, so now I'm going to recommend, if you have not already practiced a fair amount on the demo site to get a sense of what it's really like to move through the KSADS-COMP, I'd recommend you stop here. I'm recommending that you open the parent interview for the same subject you used when completing the pre-interview items, run through the introductory introductory interview items and maybe 1 to 2 supplements, test the back button, write some comments, and then review the symptom response comments report to look at your answers. So if you have not already spent a significant amount of time on the demo site and have tried running through the KSADS-COMP, I recommend that you pause this video and go do that now. All right, welcome back. So some frequently asked questions. What age children is the clinician administered KSADS-COMP appropriate? So the parent portion of the KSADS-COMP has been used with children as young as 3- and 4-year-old preschoolers. The child interview is not typically done with children less than 5 or 6. And then with the very young children, you typically would not do all of the interview. The introductory interview provides some good information, and you may target on 1 or 2 core screen items. In particular, some of the symptoms parents may not know. Parents don't always know about internalizing symptoms of sleep problems, suicidality, negative thoughts, nightmares. So you would get those symptoms. With the very young preschoolers, I sometimes use something called the Levon Cartoon Inventory, which is very good for being able to get internalizing a range of symptoms from young children in that 3 to 6 age range to augment the parent report. When new information comes up, which is relevant to a prior question, how can it be incorporated? If you're in the same module and then a parent remembers something or a youth remembers something, you can just press the back button, and then you can make a change if you need to those items. If you are past that module, there's not a super easy way to get back, but you can write yourself a note. And with the clinician administered interview, again, you take into account what the parent wrote, what the youth wrote, and then the consensus. And at that consensus interview section is when you can kind of update the information if something very significant was reported after the fact and you weren't able to put it into that particular interview. How do you handle child not knowing specific dates? Children don't really often know dates. So mostly I don't worry about it. I usually, rather than ask them about year, I ask about grade, because oftentimes kids can reflect the grade. If it's a young child, you would have typically have done the interview with a parent before the interview with the child, and you can just pull the dates from what the parent said. And if not, you just make your best guess. I wouldn't spend a lot of time worrying about it. Portions of the clinician administered KSADS-COMP state, check all that apply. How should these be administered? So the language there is really the same as is used with the self-administered. And so clearly, if you're doing an interview with someone, you can't say that. So you would basically read off the list. Say, I'm going to read you a list of different symptoms. I want to know how often, or if these are true for Johnny, and you would just read them off and you would click all that apply. For the consensus interview, how do we resolve differences in caregiver and child responses? There are general guidelines. In general, youth are better at reporting internalizing symptoms, and parents are better at reporting externalizing symptoms. Ultimately, you can't take off your clinician hat because you have to weigh that. Because while those are the general rules, I've certainly had times where I've interviewed youth where they've denied any suicidality, but yet the parent let me know that they found their child in a closet with a rope around their neck. So ultimately, it is our best estimate, our best integration of the data. And so you put the information. There's also been times where a parent is clearly very clinically depressed and they describe their child like they're really depressed. But when you meet with the child, there's no negative affect. They show good adaptation. They're doing things with their friends. They're functioning well in school. And so you have to weigh that information. So keep your clinical hat on and you will make your best estimate decision on really the rating that's most appropriate for that child, for that symptom. All right, so we're going to talk a little bit now about why we think diagnoses matter. And as an example, the same symptom, such as inattention, can be associated with multiple diagnoses with different recommended treatments. ADHD, you would want to use a stimulant medication, parent training, teacher consultation, social skills, and the like. Depression, antidepressants, cognitive behavior therapy, interpersonal psychotherapy, or behavioral activation. Inattention is also associated with bipolar, in which case you would want to use a mood stabilizer, multifamily psychoeducation group, or it could also be indication of post-traumatic stress disorder, in which case a trauma-focused therapy and safety planning would be really essential for optimal clinical care. So We're going to talk a little bit about differential diagnosis. And on the next slide, you'll see that most of the common child psychiatric diagnoses share many symptoms. A PDF of the next two slides is available on our KSADS website. And information about the following will help to facilitate differential diagnoses, whether the symptoms are episodic or chronic, the patterning of symptoms with other symptoms, and the context, home versus school, where the symptoms are most problematic. And this is just to show you on our website where you can get the differential diagnostic worksheets I'm about to show you. All right, these are hard to read, so feel free to print them out. But here we're just highlighting that the symptom distractibility concentration problems can be symptoms of mania, major depression, ADHD, or PTSD. Symptoms of irritability, again, could be mania, depression, oppositional defiant disorder, or PTSD. And key factors in making a consideration for these differential diagnoses between these common child psychiatric illnesses is, as we've said, whether the symptoms are chronic or episodic, setting where the symptoms are worst, and the patterning of the symptoms. So as just an example, if we think about differential diagnosis related to either distractibility or irritability. Okay, distractibility, if the symptoms are chronic and worse in a school setting, likely ADHD. If they're episodic and associated with decreased need for sleep, it's likely mania or bipolar. If it's episodic and associated with negative self-worth or suicidality or potentially insomnia, likely depression. Or if it's a new onset after a trauma, and there are also things like nightmares, likely PTSD. So the patterning of symptoms, whether they're episodic, the setting, are really key in helping us make proper differential diagnosis. In terms of irritability, if it's chronic and associated with a disrespect for authority, likely oppositional defiant disorder. If it's episodic and associated with a decreased need for sleep, we should be thinking mania, bipolar. And if it's a new onset after a trauma, and again, there's things like nightmares, we should be thinking PTSD. So I'm going to put a bunch of different questions on the screen right now. I'll start off by reading them. The correct answers will be provided at the end of the 10-item quiz. Question number 1, which of the following statements is false? The pre-interview self-report KSADS screen items, A, are completed only by the parent, B, are completed before administering the KSADS interview, C, are completed by both the parent and the teen, D, scores from the pre-interview self-report rating scales appear on the screen of the clinician administered interview. Sorry, my reading. All right. Question number 2, which of the following statements is true? The introductory interview, A, can be omitted in the interest of time. B, is not an essential part of the KSADS. C, helps establish rapport, provides information about functional impairment, treatment history, and relevant diagnostic areas to be surveyed in greater detail later in the interview. Or D, contains probes and ratings for scoring symptoms. Question 3, which of the following statements is true? The screen interview, A, should ideally be completed in its entirety before completing any of the diagnostic supplements. B, surveys 2 to 4 symptoms for each diagnosis assessed in the KSADS-COMP. C, provides a diagnostic overview and facilitates differential diagnosis. D, all of the above. Question 4. The probes included in the clinician administered KSADS, A, need not be read verbatim. B, can be altered to make stylistic changes to facilitate the interview. C, can be omitted if the data obtained in the introductory interview and on the parent and teen pre-interview form suggests no further probing is required to rate the symptom. D, all of the above. Question 5. If in the screen interview, threshold ratings are obtained for ADHD, mania, depression, and substance use sections, supplements for these disorders are administered in the following order. I'm not going to read these off. I'm going to let you just read. So which order would you want to do the supplements if ADHD, mania, and depression and substance use were all positive screens? Question 6. Okay, now if in the screen interview, threshold ratings are obtained in the current depression, mania, and psychosis sections, supplements for these disorders should be administered in which of the following order? So again, I'm going to let you read these and select what would be the best order to facilitate differential diagnosis if depression, mania, and psychosis had positive screens. Question 7. If in the screen interview, threshold ratings are obtained for depression, psychosis, and I think this says PTSD. Aha, sorry, that was blocked on my screen. And PTSD, supplements for these disorders are administered in which order? So again, now we have PTSD, psychosis, and depression. What order do we want to do the supplements in? Question 8. Which of the following statements are false? A, observational data can be used in rating symptom severity. B, the parent interview should ideally be completed by a different interviewer than the child interview. C, when assessing a pre-adolescent, it is best to complete the parent interview before the youth interview. D, information learned in the unstructured introductory interview, suspensions for fighting in school, can be used to probe the presence and severity of symptoms, fighting, assessed later in the KSADS. Which is false. Again, if anyone needs more time, you can pause the video. Question 9, which of the following statements are true? A, the Clinician Administered KSADS-COMP is a semi-structured instrument. B, the Clinician Administered KSADS-COMP is designed to be conducted in a conversational style. C, parent and youth self-report measures can be used together with KSADS-COMP data to derive best estimate child psychiatric diagnoses. D, all of the above. And question 10, which of the following statements are true? A, parent and youth pre-interview responses can be viewed online and are printed before conducting the KSADS-COMP interview with the parent and child. B, the diagnosis report lists current and past diagnoses and all positive symptoms associated with each disorder. C, notes that the clinician types when administering the KSADS-COMP can be viewed online or printed by selecting the Symptom Response Comments tab in the Reports section. D, all of the above. All right, these are the answers. You can check these answers against the ones that you wrote down. And I'm just going to take a minute to review these 3 questions talking about the order for the different supplements, since these are sometimes tricky. So oftentimes, okay, so here we have ADHD, mania, depression, and substance use having positive screens. The recommendation is B. So since substance use can create ADHD-like symptoms, depression-like symptoms, mania, we want to find out the dates of the substance use, the substances used before we assess any of those other symptoms. We are also recommending that ADHD go before depression and mania because chronologically there's a high probability the ADHD symptoms had an earlier onset, and we want to know whether or not there's been a worsening with those symptoms with the onset of mood disorders for them to be counting in the mood disorder sections. All right, so when the positive screens were in depression, mania, and psychosis, we want to start with D. Okay, you could flip it and do mania, depression in opposite order, doesn't matter. But the most important thing is we want to do the mood disorders before we do the psychotic disorders, because we want to find out, first of all, if they ever met criteria for full-blown major depression or full-blown mania, because you can't have a mood disorder with psychotic symptoms unless you had full-blown criteria for those disorders. And also, we're going to want to find out whether or not the psychotic symptoms were really uniquely associated with those episodes or whether they persisted outside. So getting a good sense of the mood disorder first, whether the psychotic symptoms were a part of that, will be important. And if they don't meet criteria for mania or depression and have psychotic symptoms, it would be a primary psychotic disorder. So that's the recommended order for those supplements if those were the positive screens. And if the positive screens are depression, psychosis, and PTSD, we recommend, again, we want psychosis to go last. You could potentially flip-flop the PTSD and the depression, but the answer we would recommend is D, PTSD, depression, psychosis. Trauma-related hallucinations is a very common symptom of PTSD. So you want to fully evaluate the PTSD before you get into the psychotic disorder section. Because if it only turns out that the things that they're seeing are related to the trauma, they're hearing the perpetrator's voice, they're, seeing flashbacks of what happened to them, that's not psychosis. And to be honest, a lot of times clinically, if I'm very clear that all the psychotic-like symptoms are just a component of the trauma, I usually would not do the psychotic disorder supplement because I can rule it out based on a really comprehensive assessment of the PTSD first. All right, if people have additional questions that they'd like to ask about the administration of the KSADS, you have my email. Feel free to reach out to me. And thank you very much for joining us and thinking about using the KSADS in your work.